Morning, good afternoon, and good evening to all of you who have joined worldwide. Thank you to each of you for being with us today to make this event possible. We trust that the sessions from previous chapters have been of interest and have contributed meaningfully to your professional development. My name is Natalie, and I'm the ISoP Western Pacific Chapter President and ARC's Director of Growth and Engagement, the peak body for medtech and pharmaceutical professionals. I'm delighted to host this year's session for the Western Pacific Oceania region. On behalf of the International Society of Pharmacovigilance, or ISoP, we are very pleased to welcome you all to the 6th edition of ISoP Patient Safety Day event here, held over September 18th and 19th. The World Health Organization has designated September 17th as a World Patient Safety Day to enhance public engagement in health safety and to promote global actions aimed at preventing and reducing harm associated with healthcare delivery. This year, the WHO has chosen the theme Safe Care for Every Newborn and Every Child under the slogan Patient Safety from the Start, to highlight the particular vulnerability of this age group to risk and harm resulting from unsafe care. ISoP reaffirms the objectives of the WHO's Global Patient Safety Challenge and calls on stakeholders and health professionals to professionalise and take early action in critical areas associated with significant harm in pediatric and neonatal patients due to the unsafe medication practices. These areas include high-risk medications, look-alike and sound-alike drugs, so LASA drugs, dose conversions, care transitions, polypharmacy, adverse drug reactions, and other major disruptions in the delivery of healthcare services. Our President, Dr. Angela Caro, will address a few words to you all. Please watch this short video.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
We appreciate your attention. We encourage you to contribute to the broader dialogue by sharing your reflections and experience on this event through social media using the following hashtags: hashtag ISoP PSD 2025, hashtag World Patient Safety Day 2025, hashtag WPSD 2025, hashtag ISoP Online, hashtag Pediatric Safety, hashtag Child Safe Care, and hashtag No Harm from Birth. Now, I'm delighted to introduce our first speaker, Rebecca Jane Moles, who will present on pediatric medication management at home, what you need to know about caregivers' knowledge and functional health literacy to ensure safer care for every child. Professor Rebecca Moles is a pharmacist researcher from Sydney Pharmacy School at the University of Sydney. She's passionate about medication safety research focused on vulnerable populations, including the very young and the elderly. We invite you to participate in this section actively. So if you have any questions, please put them in the chat box. We will respond to some of them as our schedule permits at the end of this whole session. So after gym session as well. And the rest will be collected, and then a Q&A list will be published on our webpage, www.isoponline.org. Without further ado, we welcome Rebecca to the floor. Thank you, Rebecca.
Thank you so much, Nav. I'll do my best to share my screen now and hope that technology is kind to me this morning. Let's see. Let me just put that on. Okay. Hopefully that is working for everybody. So thank you very much for the kind invitation to present today on a topic that I'm extremely passionate about, pediatric medication safety. So the title of my talk, as presented, is about what you need to know about caregivers' knowledge and their functional health literacy, to see what the gaps are, to hope that we can ensure safer care for every child. What I thought I would do is run over sort of three main areas in this presentation. I thought I'd start with presenting some of my own research about what caregivers know about fever management. So we've done some studies around fever management, which has included observing liquid medication dosing. So I'll be able to highlight some of those studies. I then thought I'd move on to look at, well, when we're treating a child's fever, most people present to a community pharmacy to buy these liquid medications for their children. So we've also done some research looking at how pharmacy handle these types of requests. So I will highlight some of the good and not so good in that area. And then I thought we'd leave some room for thought, how can we help fill these gaps? In our caregivers, but also even our health professionals sometimes have gaps in this knowledge as well. So starting off with the first topic, what do our parents know about fever and medicine dosing? So back in 2020, which is not that long ago, we developed a fever knowledge questionnaire. We actually did this by looking at all fever knowledge questionnaires that existed in the literature around the world. And we did a content analysis and put together and validated a true-false questionnaire. It's not highbrow, it's pretty easy for parents and caregivers to answer. It has statements and you answer it as either a true or a false statement, so it's like a test. And we delivered that to 1,000 Australian parents using a digital edge market research company. What was really interesting from that is that the scores weren't great. So if we count 50% as a pass mark, we actually only had about 59% of the participants passing the test, and no one got full marks, but the highest score was 26 out of 29. In fact, the average score was around 50%, and I'll show you some of that in a minute. And there are a couple of questions in there that were specific to medicine dosing. Paracetamol, ibuprofen, they're our most commonly used liquid medicines for children's fever. And whilst we showed that about 3/4 of the sample did know the dosing interval for paracetamol, it was a much lower proportion of the sample that understood the dosing for ibuprofen. And so we've done some other research that shows that parents actually really don't differentiate at all between those two drugs. They don't know that they're different medicines at all. So as a researcher, and not all of you in the audience are researchers, but when you get given a graph like this from the data that you've collected, you think it's falsified because it's the best normally distributed curve I've ever seen, which was actually very exciting. But this basically showed the range of parents' scores in this particular knowledge questionnaire. So you can see that everybody's bunched up at the middle in sort of either just failing or just passing the test. And there's very few up the high end getting really good scores. And there's also some down the low end getting very poor scores. If we look at each of the different questions within the questionnaire around fever management, and they followed the NICE guidelines. So they looked at detection of fever right through to the treatment of fever. We saw that there were certain questions that scored very well by most people, and I'll show you an example of some of those in a minute. But there were also some questions that scored very poorly, that there are big gaps in parental knowledge. So let's have a look at some of the good questions, if you like. So the good news is that most parents know that fever is a normal response to infection. They know that it's helping the child. They know what a definition of a fever is. They recognize that thermometers should probably be used. And they recognize that you might use a medicine to make a child more comfortable. Although in some other research, we've shown that people sometimes jump to medicines a little bit too quickly. They also knew that if your child was very young, that consultation with a medical professional is important. So these were the questions that did well. They scored highly. The ones that weren't so good are, I guess, a little bit more concerning. So there's still a lot of fever phobia out there in the world, where people, it's a very, very normal response of our bodies to an infection. You might be able to hear by my voice that I have a little bit of an infection right now. And so it would not be uncommon that perhaps my body temperature has been raised a little bit over the last few days trying to fight that infection. It's actually a good thing. And like, rarely would temperatures ever go up past the 40 degrees because we have an internal thermostat. But there's still a lot of fever phobia out there, and parents are convinced that these high temperatures are going to cause brain damage in their children, which is actually not what's occurring. People also associate teething with fever, and whilst yes, when a child has teething, perhaps they've also got another infection at the same time, but teething itself without an infection should not cause a temperature. And so this is a furphy that's out there. There's still a lot of people recommending to stick a child in a cold bath or even a warm tepid bath, or to use cold sponges. And many of these things, when we try and, physically cool the child down with these things, make you shiver, and that actually can drive the temperature back up again. So there's, again, a lot of perhaps poor practice going out there. Similarly, whilst there is research about using two medicines or alternating medicines, the guidelines right now state that really one medicine should be used only for fever. Different perhaps for moderate to severe pain, but for fever, one medicine is enough, because I'll show you in a minute, parents make too many mistakes even with one. So trying to get them to use two and alternate is just causing a myriad of problems. So again, based on guidelines, this was a statement where parents got the wrong answer. And they do not know the dosing interval, as I mentioned before, of ibuprofen. And even if a child was doing well, they were still quite concerned and wanted to seek medical advice early, which, is not necessarily a bad thing, but it's not always needed, which is the question said, always be consulted. So when we then, after this study, or actually around the same time as this study, we also did one where we sat one-on-one with parents. And so in our research, over 300 parents, we've sat with one-on-one with a fever-based scenario, and said, your child feels hot, what would you do? And we've had a range of medicines and liquid dosing. So here's a couple of the studies here. And I've got one other that we did where we followed parents up with questions about, when you said you would do this, could you explain why? And so I want to present some results very quickly from that one. So we'd sit with a parent one-on-one and say, we'd ask them, what's your youngest child? Let's say they were 2. So we'd say, your 2-year-old feels a bit hot to touch, but they're still eating, drinking, playing. What would you do? And many would perhaps say I'd measure the temperature. Others might say, oh, look, I'd just keep an eye on them. Some people would jump to a medicine immediately, just saying they feel hot. I'm going to dose them. Whatever they did after that first prompt, if they hadn't dosed, we then said, well, you took a temperature and it's 37.9 degrees Celsius. What would you do? And again, people had different things they'd explain to us they'd do. At that stage, many parents decided to dose their child with a medicine. For those perhaps that didn't, we then went on to prompt 3 and said, later your child's temperature is even higher and they're now appearing a little bit more lethargic and miserable. What would you do? And obviously at any stage somebody decided to use a liquid medicine, we recorded what medicine did they use, what dosing device did they use, what dose did they choose, and what did they then go to measure. And so we were looking at whether they handled that fever scenario correctly or incorrectly, and we had an algorithm prepared for that. And then, of course, we analyzed that data. After they did that and we observed the dose in this last study that we ran, we also then ran an interview with them immediately after and said, you chose to give your child a dose of 9 mils. Can you tell me how you came up with that dose as an example of a question? And then we coded those interviews. So in the study that we ran most recently, which was with 101 caregivers, you can see there that these caregivers had a median age there, and most of them were mums. This was actually quite an intelligent cohort. We did recruit them from the Parents Network group at the University of Sydney. So most of these people, 85%, had a university degree. So they may not even be indicative of the general population. They're certainly quite high in socioeconomic status. The age of their youngest child was 2 years, and they were mostly a first or second born child. What was encouraging was that 83% of this sample used a syringe, so that was fantastic. But that did mean that, a proportion, 17%, used a measuring cup or a spoon or something that perhaps is less accurate. What for me is the most concerning is even with the packages of medicine in front of them with all the directions on them, only 55% of the sample actually chose a correct dose for their child's weight. So that already means that nearly half the parents out there, even with the box in front of them, are perhaps choosing the wrong doses from these products. 87% measured their intended dose, but we did see some deviations. So I remember clearly a parent saying, I'm going to give them 4 mils, and then proceeded to measure 6. Just a simple error in using that syringe. We asked them, look, if in a few hours' time, so we asked them what dose interval would you redose if your child was not better. Most people got the dosing intervals correct. Majority people did choose paracetamol, so back to that fever study, which was the questionnaire. If that's the drug of choice, people seem to know the dose interval, but they don't necessarily know the dose interval for ibuprofen. We did say, would you use the same medicine or would you alternate? And encouragingly, again, about 70% said they'd use the same medicine, but that also meant 30% would alternate, which is at the moment against or differentiates from the guidelines for fever management. But unfortunately, when you put that all together, so knowing already about half choose the wrong dose, and then some of them, even with the right dose, then measure the wrong dose, etc., and some had an incorrect interval. Unfortunately, only about 33% of the sample actually got everything right in this particular scenario. And I'd really like to share with you one of the qualitative quotes. So I had a mum here who said, look, I'd veer on the lower side. She said 25 kilos. He could actually have 8 mils. I go, all right, his age, 6 mils. And then I go, actually, I'll go a bit lower. I'll give him 5 mils. So you can see that there's this fuzzy logic that's coming into play when parents are measuring liquid medicines. Now, by all means, a child who's 25 kilos, and I double checked this was a relatively tall child, not an overweight or obese child, but this particular child who probably should have got an 8 mil dose of paracetamol ended up with a 5 mil dose. Now, no children were actually dosed in this. It was all a simulated scenario. But, it's interesting to see how parents are making these decisions. So we moved on from this study actually saying, well, parents get their information from a pharmacy. What are pharmacists doing? And we know that we train our pharmacy students at our university in this, so we wanted to actually have a look in these simulated scenarios where somebody walks into a pharmacy and asks for some fever management for their child, what is happening. So our students at university did pretty well. So most of them, 90 odd percent, could handle that scenario. When we went out and mystery shopped in a community pharmacy, we showed that about like the pharmacists that we visited, around 3/4 of those managed a scenario quite nicely and pointed out the dose to parents on the packaging. But our pharmacy support staff, which are often the front of shop and really commonly the first people we see in a community pharmacy, were unfortunately not handling these scenarios perhaps in the best way. So we then actually did another mystery shopping study where we actually did repeated visits where we did some coaching and feedback. So we visited a pharmacy and had a fever scenario. We had many scenarios in this particular study, but you can have a look at the pediatric fever ones here, which was one of it. When we went back in multiple visits, we actually had 9 visits in these pharmacies. Every time we did a mystery shop, we then walked back in after that mystery shop. Obviously, we had different actors come in, so they didn't recognize us every time. And we were able to provide some feedback and coaching. And what we were able to show was that after feedback and coaching, the appropriateness of the intervention. So if you have a look, overall appropriateness was at 47%. So about half the parents were getting the wrong information, if you like, or inadequate information. And that could move up to 94%. Getting the right sort of information, which was great. And again, in the questioning, we saw that not enough questions were being asked, and we were also able to improve the questioning in this fever-based scenario. But I think there's still plenty of room to do a bit more. So I guess just finishing up, what does this mean? What can we do, particularly as healthcare professionals or perhaps as researchers, to try and fill some of these gaps? And I'm not sure I've got the answer, but just a reminder in the studies that we had done, about 15% of the caregivers overall managed the fever scenario appropriately, with only 33% getting doses right every time in their measurement. So there's certainly an issue with perhaps being too quick maybe to treat a child's fever. At the same time, we obviously need to be aware of red flags and when a child needs referral. So if they're under 3 months, they should be getting to a doctor immediately. If they're really lethargic and not eating, drinking, playing, and you know your child and they're just not well, then we certainly need to be getting them off to the doctor. But we saw that people were dosing pretty early on in many of these, in the studies we've run. They're very good at using the wet cloths or sticking their child in a bath or a shower. And then, as I said, I'm more concerned as well about the inaccurate doses. And whilst many of them were underdoses, we still had about 10% of the sample overdosing, with up to a 2-fold error being observed, and a lot of people using 2 medicines. So dosing must be tricky, right? Like it's not easy. If I look at the bottle of the paracetamol or the ibuprofens in Australia, many of them have age bracket, then they have a weight bracket, and then they have a dosing range. So they'll, as I showed you on that picture before, 6 to 7 years, 20 to 22 kilos, 6 to 7 mils. So as a mum or a dad, I'm like, well, which one do I give? Do I give 6 mils? Do I give 7 mils? Or I don't know, they're 6 years, but they're 25 kilos. Which one of these, bits do I use? And in the UK, back in 2011, this was also an issue. And so they transitioned to actually dose banding with their Calpol, their leading brand, which would be sort of equivalent to in Australia our Panadol brand. And they actually moved to what they call dose banding. So there's none of this 6 to 7 mils or 7 to 8 mils. There's just your child's this age, you give them this dose. And I'm just wondering whether, that perhaps will spread throughout the world. Now, I'm not going to say that that's more accurate. Obviously, weight-based dosing is probably the most accurate, but I'm worried about how many people are getting underdosed or potentially overdosed because of the confusion on the packaging. So this is what a Calpol packet sort of looks like on the back here. And so you can see that the dose banding is there for just a standard dose versus a range of doses. So, of course, some of the pros of that would be that it would simplify dosing, it reduces calculation errors, it could improve adherence and facilitate standardization. But as I already said, of course, it would reduce a little bit of accuracy and it does have risk in extremes. So, if you have a very small 6 year old or a very, very large 6 year old, then we might need to not use that dose banding. So that's important. And it does assume, of course, average pharmacokinetics. The other thing that's come up in this research often is, this one or two drugs. People say, but Beck, the doctor told me to give two. And I think that, again, that two analgesic agents is certainly recommended for moderate to severe pain and certainly under the instructions of your doctor if they've told you to use two medicines. I've got no issue with that. But for community pharmacists and the general public walking into a community pharmacy, if it is a simple fever, temperature, and there are no red flags, the child's sort of eating, drinking, playing, maybe they don't need a medicine at all. That would be what I'd advocate for first if they're eating, drinking, playing. If they're just a little bit sniffly and a little bit miserable, but they're still, engaging. They're not lethargic and, really listless. That would be something I would definitely say get off to the doctor with. Then we already just saw how many mistakes they make just with one medicine. I just think giving them two, we're just increasing that risk of dosing errors. And then I guess moving on from that is what dose device is the best one to use? And many of our liquid analgesics or antipyretics, I should say, so our fever medicines, they used to come, a lot of them, with a measuring cup. And I don't know if you've ever tried to use a color-free syrup in one of those medicine cups, and the markings often aren't in black either. And so it's very hard to differentiate between 9 mil, 10 mil, 11 mil. They all look pretty much the same. You need very good eyes, difficult to do in the dark. So would certainly advocate for syringes being used over and above medicine cups, and many products now come with a standard syringe in the pack. But, if we did move to more standardized or dose banding, there have been dose right clips, which are these colorful things on the left that can be inserted into a syringe so that you can only draw back the amount that you want to give based on the particular dose right clip that's been put in. Or the kids easy dose is another one. Again, it will only work for standardized doses. Well, disclaimer, I guess a complete conflict of interest, but I'm an inventor of a new dose device that's patented, but certainly not on the market yet. We've still got to do a lot more testing. It's at a prototype phase, but it's called set dose. But the idea of set dose is that you could make the device to fit to any standard syringe, but the coolest part of it is that a card here, so this white part, could be set by the pharmacist. So if you went to the pharmacy to collect a liquid medicine, doesn't have to be a fever medicine, it could be a prescription antibiotic, um, that pharmacist could set that card to any particular dose. So I was speaking with Jim the other day, and he said he prescribed an antibiotic that ended up at a 6.8 mil dose, and then, or I think it was a 5.8 mil dose, and then sort of made it 6 mils so it would make it easier for mum and dad. Well, again, we could even get this dose card to that accuracy of 5.8 mil if required. But if you're interested in set dose, please do contact me after this talk. So, final slide. I think as healthcare professionals, what do we need to do? Well, we need to spend more time with each caregiver every time we're dosing a liquid medicine. The functional health literacy has some gaps, and I totally understand why. We've made the packaging often very confusing. We need to show our caregivers how to use a syringe and where the markings are and where you need to draw that back to. We need to explain that doses might change based on weight if we keep going with weight-based dosing. So they might need to weigh the child, and we might need to point all of this out on the box. Definitely ensure that they understand the dose intervals and they know the maximum amount of doses that can be given. From a research perspective, I think we really need, some sort of standard educational intervention to target caregivers. I know fever just, probably doesn't sound that exciting, but every single child probably born in the world will have a fever at some stage in their life, and it will need to, well, it may need to be treated. It might not need treatment, but it certainly needs some management and some care. And so I think we need some educational intervention there. Perhaps even also for our healthcare professionals. I'd love some different product labeling in the future. And, as I said, I think some dosing devices to try and make it easier to avoid this ubiquitous issue of incorrect medicine dosing. So, thank you everyone for giving me this time this morning. My email address is there. I'm very happy to touch base with people in the future. Thank you.
Thank you very much, Rebecca. I really appreciate your fantastic session there. Without a doubt, an important topic on accurate dosing to discuss on World Patient Safety Day. If you could kindly turn your camera off, but remain connected as we will we'll do the live Q&A session at the end of the presentations. We do invite you to submit your questions for Rebecca in the chat function while we listen to the next presentation. So now let me introduce our second speaker, Jim Buttery, who will be presenting on the topic using global real-world data to support vaccine safety and confidence for newborns and children. Professor Jim Buttery, expert in pediatric infectious diseases and vaccinology, leads vaccine safety at the University of Melbourne, RCH, MCRI, SAFIC, and GVDN, with over 280 publications using big data. Welcome, Jim. Please proceed with your presentation.
Thanks very much, Nav, and thanks for the opportunity to speak on Patient Safety Day. So I'll just hope that my screen sharing works. So I'm going to use a couple of opportunities of work we've done to illustrate how we can use big data to support vaccine safety and confidence. But first, I'd like to acknowledge I'm speaking from Sydney in Australia. and I'd like to acknowledge the traditional owners of the land on which I'm presenting to you from today, which is the Wallamatagal people from the Durag Nation. So the first study I'd like to talk about is a study that came out earlier this year from our state, Victoria, looking at the safety of hepatitis B vaccine in extremely preterm infants, related to one of the most common complications of extreme prematurity, which is a chronic lung condition called bronchopulmonary dysplasia. So, as background, I'm sure you all know that hepatitis B is the most common bloodborne infection in Australia, and certainly the most common chronic condition globally, and results in a huge number of deaths internationally from chronic liver disease and also hepatocellular carcinoma. The major modes of transmission are, in most places, are from mother to child at birth, but there's also horizontal household transmission, parenteral transmission, and other mucosal transmission. And we know if you're infected perinatally, 90% of babies go on to develop chronic hepatitis B during childhood. So in Australia, the response is that all children are recommended to receive birth dose hepatitis B, no matter what your gestation at birth is. And for those known to be born to Hep B surface antigen positive mums, they also receive additional hepatitis B immune globulin. But we know that screening programs throughout the world don't always pick up all hepatitis B positive mums. And universal dose hepatitis B has been recommended globally and been implemented almost everywhere. And Australia is rather unusual in that it's one of the few countries, together with South America, who follow the WHO guidelines that all babies, no matter how premature they are, should receive a birth dose of hepatitis B. And so, as you can see there, the reason for that varies a little bit, in that we know that for babies born who are light or under 32 weeks of age, they typically develop a lower response to hepatitis B, which many countries address by waiting until they're bigger before they have their first dose, or have an additional dose at 12 months. We also know from nearly 3 decades ago, from work done by Anu Marchand in the Gambia, that depending on the vaccine you receive at birth, it can influence the immune response your early neonatal immune system develops in, if you like, in a Th1, or which is more cytotoxic, more fighting infection style of immune response, or a Th2, which is slightly more allergic-based response. We know that babies who are given BCG at birth have more of a Th1 immune response to other antigens. And we also know that if you're given BCG at birth with hepatitis B, the immune response to the hepatitis B is also increased compared to babies who didn't receive BCG. So the clinical concern that developed in Australia came out of a very detailed prospective immunological study in a limited number of extremely preterm infants. And that study showed that those babies who had a Th2 immune polarization measured by cytokines were more likely to go on to develop BPD, or bronchopulmonary dysplasia, the chronic lung disease of prematurity. And that's associated with long-term morbidity, including asthma, cardiac dysfunction, and it has been associated, although it's unclear the causation, with neurodevelopmental disability. And that work came out of Monash University with Jason Lau as part of his PhD, where he showed that Th2 bias was linked with an increased risk of BPD, and birth dose hepatitis B was also associated with Th2 polarization, although they were not able to associate hepatitis B receipt with an increased risk of BPD. And so there was a need for a much larger sample size and a real-world safety evaluation, which is what we went on to do. So BPD, as I mentioned, is only a condition that's seen in premature infants, and it's related to a combination of factors, including immature underdeveloped lungs, the use of oxygen and also ventilation for many preterm infants to support them, as well as the interplay between the infections that they may catch within the neonatal unit, as well as genetics. The subsequent inflammation decreases the alveolar capacity and causes fibrosis, which can go on to have a number of complications, both acutely as well as later in life. So our study objective was to determine whether birth dose hepatitis B increased the risk of BPD in very preterm infants, and our group was babies born less than 29 weeks gestation. So we used a statewide linked data set, which combined data from our perinatal data collection as well as our Victorian admitted episodes data set, and that was linked to the Australian Childhood Immunisation Register. And so for the years 2017 to 2020, we were able to examine 818 babies who were born less than 29 weeks gestation. So the exposure was if they'd received Hep B vaccination within the first 24 hours of life, and the outcome was a diagnosis of bronchopulmonary dysplasia at 36 weeks postmenstrual age, which is the standard age in neonatal protocols as when you make that diagnosis. So this was done using our Vaccine Safety Health Link, which, as I mentioned, was a linked statewide data set that includes perinatal, hospital, mortality data sets, also linked with immunisation records and notifiable disease. It covers the entire population of Victoria, which is about just under 7 million people, and it can find events that won't necessarily be notified to a reporting system. And what we get is a linked, completely de-identified data set available for analysis. So the first step we did was identify our cohort of babies who were born less than 29 weeks gestation. We then looked to see what their exposure was as to whether they received Hep B vaccine within 24 hours of birth or not, and then whether they received a diagnosis using ICD-10 codes for bronchopulmonary dysplasia. Because this is a real-world study and it's a retrospective cohort design, there could be factors that influence whether clinicians or families choose to receive birth dose hepatitis B. We also looked at potential confounders that were available in the data sets in which we used. And so that was in conjunction with neonatal experts. And the key confounders that we adjusted for in the directed acyclic graph, or DAG, was birth weight, their APGAR score at birth, maternal age, maternal smoking, and congenital heart disease. So this is what the, if you like, the final analysis tables looked like, and we looked at that using a Poisson regression model. And so the bottom line is that, as I mentioned, from just over 10,000 preterm babies born during that 4-year period, we included 818 preterm infants less than 29 weeks gestation. And the bottom line is that the adjusted relative risk for babies who'd received birth dose hepatitis B vaccine for developing BPD was less than 1. In other words, they appeared statistically to have a lower risk, although, as you can see, the confidence intervals actually reach 1. So what we were able to say very confidently was that there was no evidence of increased risk of BPD in preterm infants who received birth dose hepatitis B. Also, we looked at 3-month mortality, and what we were also able to show was that there was no evidence of an increased risk of mortality in those preterm infants who received the early Hep B birth dose. So overall, this has some global importance because it reinforces the role of immunisation even in high-risk neonatal care. And that was particularly relevant to Australia because the study that had raised the question had also been a Victorian and Australian study. It supports the existing WHO recommendations that all babies should receive birth dose hepatitis B, and we've been able to communicate this to Australian researchers and neonatologists. And interestingly, the study was also presented overnight at the US Advisory Committee on Immunisation Practices meeting by the CDC to help support the ongoing US hepatitis B birth dose program. So I'd particularly like to thank Hannah Morgan, who led this study as part of her PhD work, as well as the rest of the team within our group, James Boyd from La Trobe University, as well as Claudia Nold-Petrie, Atul Malhotra, and Marcel Nold from Monash University. So now I'm going to move to a completely different topic, which is the use of artificial intelligence in vaccine safety and communication. And we're currently using AI for vaccine safety signal detection, for bot detection, to look at sentiment around immunisation, but also to identify and manage misinformation. So first of all, in terms of vaccine safety signal detection, many will be familiar with Maurice Hilleman, who was responsible for developing many of the routine immunisations we use in our infant programs globally. And he was oft-quoted as saying, "I never breathe a sigh of relief until the first 3 million doses have been delivered," essentially illustrating that although well-conducted phase 3 clinical trials are very good for common and most uncommon adverse events, most clinical trials, even large ones, are not powered to detect rare adverse events. So as part of that, in Victoria, we've looked at a range of different data sets that can answer questions around where adverse events might be reported. Now, clearly, the more severe the adverse event, the more likely it is that they will present at the top of the pyramid, for example, to hospitals or emergency departments. Milder ones are more likely to present in general practitioners or primary care physicians. And then as you work your way down the mildness spectrum, they may ring up for health advice, or they may just whinge about it in social media or look up the internet and look after themselves for that. And typically, as you go down the severity spectrum, you go up in the frequency spectrum. And we've utilised social media in particular to look at the bottom of this pyramid. And interestingly, although Donald Rumsfeld, the former US Secretary of Defense, was not known for his interest in health whatsoever, he was helpful in these characterization of the known knowns, or the facts, which corresponds pretty well with the known reactogenicity around vaccines, the known unknowns, which are things that we are not sure about but may have come up in clinical trials we want to keep an eye on, or the adverse events of special interest. And then there's the unknown unknowns, which, if you like, are the black swans events, the things that we couldn't have predicted, like the vaccine-induced thrombosis and thrombocytopenia that we saw with the adenoviral vectored COVID vaccines. So during her PhD, Sadiq Kademi, a young engineer, had developed a two-phase machine learning approach to identify people in Twitter complaining about their own influenza adverse events. And what she was able to do was identify initially vaccine-related social media posts, then the subclass of those that included personal health mentions, and then within those talking about the adverse events they actually experienced themselves. And she was able to do that with a high degree of accuracy. We then took that further because it emerged some conversations relating to menstrual issues relating to COVID-19 vaccines. And so we looked at this in two different ways. The first, the blue line, is COVID activity globally. And whoops, I'll go back. The grey shaded area you can see is when COVID vaccines were introduced. And as you can see in the left-hand panel, the non-personal tweets, so the ones coded as not being personal, remained relatively stable throughout COVID. Whereas on the right-hand panel, those relating to their own symptoms went up almost in parallel with the introduction of the COVID vaccine program. Now, that in itself suggests there might be an issue, but it certainly doesn't prove anything. But it was useful as a signal detection technique. So what we were able to do, first of all, is characterize some of these. And as you can see, not all of these comments are about adverse events. They're people asking questions or people commenting on the issue. So we then went into a different data set, a large primary care data set, and this was the Polar GP data set, which contains over 13 million patient records. And what we were able to do is, using a self-controlled case series analysis method, is look to see, were women who'd received a dose of COVID-19 vaccine more likely to have a first presentation of a new menstrual issue compared to any other time in their lives. And so we looked at adult women between 18 and 42, and what we were able to show is that there was a 15% increased risk of having a new menstrual issue presentation to your primary care practitioner in the 6 weeks following COVID-19 vaccination. Now, that was significant for mRNA vaccines, and in particular for the Pfizer mRNA vaccine, but it looked a similar size of effect for the other COVID-19 vaccines, although did not reach statistical significance. We then were able to, and I'm not sure if you can hear this, but you can see the text there. We released this on TikTok to feed back to the women who had expressed immense frustration that they'd been to their practitioners to talk about their symptoms and they'd not been believed that this was associated with vaccination. Interestingly, TikTok took this down for misinformation, despite us having scientific data proving it. On the bright side, Instagram kept it up. So then, looking at the other ways we've used social media to support vaccines, we know, or all of us are acutely aware of the dangers of social media now to influence political views around the world. In Australia, that's resulted in a social media ban for children under the age of 16. And we also know that not only does Facebook misinformation decrease your intent to vaccinate, even with a single view. So this is a really interesting study. Facebook had a period where they were flagging misinformation with a lot more misinformation that was not flagged. And what they found was that each time you viewed a single time misinformation, that decreased your intent to vaccinate by 1.5%. But interestingly, the effect of the non-flagged misinformation was far greater, simply because they were viewed so many more times. We also know that misinformation decreases intent to vaccinate and also the uptake of vaccines, no matter how much people trust their government or their healthcare providers or non-government organisations. So social bots, we know, have had a role in elections, in the US elections, in the Brexit vote, and then, as we're all painfully aware, during the COVID-19 pandemic. So we then further developed, in conjunction with Mohammed Javed, Sadiq further developed her data mining approach to vaccine mentions, so that we could not only look for vaccine adverse event mentions, but also look at misinformation, as well as conversations led by humans versus those accelerated by bots or automated large language model machines. And so what that has developed into is a service called VaxPulse, where we look at globally comments around vaccination. We classify them with respect to the subject matter as well as the vaccine they're referring to. And we also identify misinformation trends, with the purpose behind this being that if we detect emerging misinformation trends in a region or a country, we can notify key stakeholders rapidly so that they can decide whether or not this needs responding to before it drags on to and the effect of any education campaigns may be too late. Sure what happened there. So VaxPulse, what it does do is, additionally, it also identifies key religious and social influences through network analysis. We can map information flows and community interactions. And what we've certainly found is that if there's a concern within a community in one part of the world, the expatriate members of that community in other countries quickly adopt those concerns. We've also been able to analyse the spread of misinformation, not only by influencers, but also by bots. So that's resulted in this learning health system for VaxPulse, where we identify the misinformation. We have a library of responses that have been shown to work in other settings. And so when we do identify an emergent theme, we notify key stakeholders. They can choose to not respond, use one of the suggested responses, or use their own response. But whatever they do, we also analyse what happens, and then that feeds into improving our library of responses. And these are the partners that are so far part of VaxPulse, including WHO, colleagues in Indonesia, the Philippines and Ethiopia, Canada and India and Hong Kong. And finally, I'd like to thank our wonderful team at the Centre for Health Analytics. Thank you very much.
Thanks, Jim. Again, a fantastic presentation on vaccine safety and misinformation. So we kindly remind the audience to submit their questions for Jim now, and also Rebecca in the chat function. So we can ask them these questions to respond to. And also to continue the conversation on social media using the hashtags displayed on the screen. And I hope that will come up soon. Okay, so let's have a look at questions from the audience. Are there any questions? I might start off with one. So Rebecca, if you'd like to turn, oh, you're on, great. So Rebecca, how do you select doses of analgesia for children who are overweight?
Yeah, it's a really good question, Nav. So all of the doses, even if we went to dose banding, would still be predominantly based on ideal body weight. So if a child is overweight or obese, actually paracetamol, ibuprofen, they don't really disperse into the adipose, the fatty tissue. And so we can end up, unfortunately, overdosing our overweight and obese children. So we should be going with ideal body weight. So we should be taking that child's height and looking at what would be the ideal weight for that particular height. And we dose based on that, not on their actual body weight. But yeah, bit more tricky in our children. And I was just looking at some data the other day that sort of says that 12 to 15% of children in New Zealand, for example, are overweight or obese, and I would hazard a guess that those facts are pretty similar as well.
Thank
Yes,
you.
and Jim's just written something in the chat, which I read out. So, yes, okay. And so Jim was saying that, his first child was born in Europe and remembers that at least in one country, the syringes were graded by weight rather than volume. I mean, anything that we can do to make this a bit easier would be great. But for that person, if they were graded by weight and they were obese or overweight, that may not work either. But yeah, thanks, Jim, for that too.
Excellent. Any other questions for Rebecca or Jim?
I actually have a question for Jim about
Yeah.
vaccines.
Sure.
I know in some of the other research I've done as well, parents are really quick to, or perhaps even, yeah, way too quick to dose before their infant vaccines. And I know that for meningococcal, that's probably quite important, that certainly the adverse effects of that vaccine might warrant a dose of paracetamol at the time of injection. But most others, my understanding is that, unless the child actually does have a temperature or fever, or more likely perhaps the pain at injection site. Have you got any comments on the dosing of pre-dosing or prophylactic dosing prior to vaccinations?
Yeah, so we know, thanks, Rebecca. We know that for the meningococcal B, the Bexsero vaccine, the reactogenicity in the clinical trials was very high. And we also have phase 3 clinical trial data showing that if you did essentially dose just before vaccination and then 2 more doses in the first 24 hours, there was a significantly lower rate of fever and irritability post-vaccination in those child. So the only one we really recommend, if you like, anticipatory or dosing before any symptoms develop, is for the MenB vaccine. And for other vaccines, we would typically recommend only if symptoms develop.
Thank you.
And I've got one for you, Jim. What are the limitations for social media surveillance?
Yeah, so social media is fantastic because it gives you an insight into what people are thinking and talking about, and obviously the misinformation running around. The limitations largely come down to we can only access what we can access. And that varies in time as the billionaires that own social media platforms change the rules at their whims. But also in many countries, platforms like WhatsApp are the most used. And obviously, one of the reasons they're so well used is because they're encrypted and they do provide that privacy, which means we can't get into them. So, what we're continuously doing is as more social media platforms arise, we're looking to get access to them, but also we're quite reliant on discussions such as in WhatsApp spilling over into other platforms, in particular into video platforms. And I'm sure that anyone who's looked at YouTube or those similar platforms knows that there's a transcript being recorded by AI in the background for all of those videos, and we're able to scrape, if you like, the language used in those videos.
Okay, excellent. Rebecca, what about were most of the poor dosing choices in your study overdoses or underdoses?
Yeah, look, as I think I might have mentioned that, but I think, yeah, the majority were under. And so parents being extremely cautious, which I'm not, that's not a major drama. Obviously, you know, overdoses are way more of a problem, right? Like because of the consequences, particularly with paracetamol. If we continue to give what we call supratherapeutic doses, so perhaps doubling the doses or dosing quicker than that or more than 4 times a day, and you do that for a couple of days, unfortunately, you will perhaps cause some liver toxicity in children. So the majority of our doses were actually underdoses. So of course there's less safety concern there. The problem is that if the child actually really is, sick, and this is what many of the parents said, they'd say, oh, well, then I might not wait the whole 4 hour interval. So I'll give like half a dose, which is, a subtherapeutic dose. And then they go, and then I might not wait the whole 4 hours. If they're still a bit sick 2 hours later, I'll give them a bit more. And that's my concern, is that these underdoses potentially end up leading to supratherapeutic doses because they're being dosed a little bit more regularly. Other things parents said is that if I give the first dose, possibly a lower one, and then they're sick a little bit later, I'll go to the maximum dose the next time with another medicine. And already they've got the first medicine wrong, so that does worry me. So about 10% of the observations we saw were overdoses, not particularly high. We gave everybody a 5% leeway as well, so we said that the dose was correct if it was plus or minus 5% of what should have been given for that child's weight. But yeah, at like about 10% were overdoses, with one being a twofold error, which is not so bad. But in many of the literature, we often see with liquid medicines, we even see tenfold or even 100-fold errors because of decimal points and people getting confused with those. Again, not in fever management, but just in liquid medicine dosing, for example, where you've got to do a calculation. So our kids make everything a little bit more complex with doing milligrams per kilograms and having to do some math. And then if you get that decimal place in the wrong spot, particularly when doses are very, very low, doses like zero point 0.1, it's very easy for a 0.1 mil to unfortunately be interpreted as a 1 mil dose, and that's a 10 times dose error.
Yeah. And you were talking about, the potential for liver toxicity when there is overdosing that occurs. Is that liver toxicity reversible or is it permanent?
Well, it depends on when you get to it. So we do have, a great antidote, if you like, acetylcysteine for paracetamol overdoses, but it needs to be administered within time. And again, with children, the overdoses we see are more commonly these supratherapeutic doses, which have happened over days, whereas in adults, usually we see a large ingestion of paracetamol in a one dose, which is often not accidental. It might actually be intentional that somebody's tried to take a large dose, and we can get that acetylcysteine in pretty quickly. I would like to say, however, I know I'm talking about doom and gloom here. I think I'm pretty sure we've only had 1 to 2 paracetamol related deaths in pediatrics in the last 10 years in this country. So, we don't have corpses lying in the streets because of these errors mums and dads are making. They're all trying to do the right thing by their children. I'm just concerned about how much error is out there. Whilst it's not all totally unsafe, I'm just, it would be great if we could give our kids the best doses, and perhaps even no doses oftentimes. Yeah.
Yeah, okay, good point. And Jim, I wanted to ask you something. I was really interested when you're talking about sort of these um, not chat bots, but these bots that are going in for social media and actually creating information. How do you tell the difference between a real person and a bot?
Yeah, it used to be relatively easy. So if you go back 5 years, we did an initial study which Mohammed Javed led, and we were able to use a variety of bot detection techniques, which largely rely on the use of language. But like everything else, the bots are now employing the large language models that are so effective in ChatGPT, etc. And as a result, they've become much harder to detect. So we have to run them through multiple detection methodologies, and largely, if you like, it's how they use words is the way you capture it. What we do know is that although bots don't just further misinformation, they can also forward positive and neutral messages as well about vaccination. We know they preferentially accelerate negative sentiments, and in particular misinformation around adverse events.
Right. And how do you choose to investigate which possible adverse effects are complained about on social media? Like, what makes one more important than the other?
Yeah, well, I guess anyone who's looked at social media knows it's shall we say, rather rich with complaints about everything. Um, the where we preferentially look is, one, do we think there might be a real problem? And two, is this a concern that is likely to impact at the immunisation programs? So the menstrual issues was an adverse event that was acknowledged by many women that it wasn't particularly severe, but they were immensely angry that no one believed them. And so that level of frustration and loss of trust in the health system to us meant that it was an important adverse event to validate one way or the other, so that we could feed back that their concerns had been taken seriously, whatever the outcome of the study was.
Excellent. Thank you for clarifying that. Are there any other questions for the speakers? I don't see anything coming up. I'm not sure if we're having some sort of technical difficulties here in terms of the questions. or whether you guys have done such an incredible job that people don't have any other questions to ask because you've answered all of their questions. So thank you both, Jim and Rebecca. We really appreciate all of your efforts today in terms of sharing your knowledge and also responding to these questions. So our time has come to an end, and as I said, we'd like to thank the speakers for their contributions to making World Patient Safety Day and this event possible. And the focus of this session, as we discussed, with the theme of safe care for every newborn and every child. So we'd like you to continue sharing your experiences and your comments about ISoP's 2025 Patient Safety Day on social media, and kindly join us for the upcoming presentation from the Asia region. That will begin at 5:30 p.m. New Delhi time, which is about 10 p.m. Sydney time. If you'd like to visit our ISoP online Facebook page or our YouTube page, or YouTube channel, I should say, to view this webinar or any other webinars from this Patient Safety Day event, please do so. And we'll publish the recordings from the event in the next few days. And if you're not yet a member of ISoP, we invite you to join an international network committed to scientific and education innovation in pharmacovigilance and to the global promotion of safe medication use. On behalf of myself and ISoP and the speakers today, thanks so much for your participation.